Bismillah ar-Rahman ar-Rahim. Today we will speak about the Alport syndrome and how we can deal with this case in part 3 MRCOG. So, first thing we need to know about Alport syndrome. What is Alport syndrome? So, Alport syndrome, it is one of the inherited condition which run in families, and it affect one of the protein called collagen 4, and this collagen 4 play an important role in the blood vessels wall structure, especially those present in the kidney and the eye and the heart and ear. So the people who have this Alport syndrome normally will have kidney problem, heart problem, eye and ear problem. This Alport syndrome is the second most common inherited kidney disorder in the UK after polycystic kidney. And most of the people who have this Alport syndrome will have renal transplant at young age or even renal dialysis. The main pathology of this Alport syndrome that it increases the protein excretion through the urine. So the people, normally the pregnant woman has increase in the protein in her urine, and this may be due to increase the blood flow during the pregnancy. So the people who have Alport syndrome has a far higher amount of the protein in her urine, and this will worsen her kidney function during the pregnancy. So when this case appear in the exam, the most important thing that you wanted to know that it is inherited condition, and this problem can run to the in the family. So this patient can transmit the Alport syndrome to her baby. You have to counsel her about that, and this is affecting her kidney and her eye and her ear. So how will be the follow-up of this patient during the pregnancy? As we said, this is an inherited disorder. So there are many ways of the inheritance of this gene. And the most important is it can be X-linked dominant. So if we say, for example, in the X-linked dominant, the father is the one who is affected and the mother is unaffected. So you know that the father gave the X chromosome to the daughter. So there will be the percent is 50%, right? So there will be a daughter affected, and the son will be unaffected, and the other son will be unaffected. Okay, so this is if the father is the one who is affected. If the mother is affected, still the percentage is still 50% as well, but there will be one of the son may be affected and one of the daughter may be affected. If we say this is the affected mother and this is the defect gene, which is in the blue color, so this X can go to this daughter. X and X will make this daughter, and X and Y, this will make this son. So one of the son will be affected and one of the daughter will be affected. So this woman, our woman today, who has Alport syndrome, the Alport syndrome in her case is X-linked dominant, so there will be one of the son will be affected, one of the daughter will be affected, so the percentage is still 50-50. All right, so we have an example today. This may be a case which may appear in the exam. So you are in the antenatal clinic and about to see Miss Mary Adam, 20 years old patient who came today to book her pregnancy. And she was referred by her community midwife because she has missed her period and she has a post-pregnancy test. She is known case of Alport syndrome, and she was diagnosed at the age of 13 by renal biopsy and genetic testing. You are today you are assisted for communication with the patient, information gathering, patient safety, and applied knowledge. This is the domain they will be assisted for. And you are today expected to take relevant history from this patient, address the patient concern, and put management plan. So as a routine or as normal, usually we go and introduce ourselves to the patient and confirm the identity, all right, by any of your ways, and check the purpose of the meeting, okay, and make sure that why the patient is here today, and check expectation of the patient, check the concerns or any expectation from the patient from your meeting today. Normally, with the patient who has a medical disorder, when they came to book the pregnancy early, okay, we put some appreciation about their care about the pregnancy. So we may say it is very good to seek medical advice once you become pregnant. It should dedicated how it show how dedicated you are toward your coming baby. What agenda to your discussion today? So yeah, Mary or whatever her name, Miss Mary. We will discuss today the management plan of having an Alport syndrome, or we'll take you through the course of Alport syndrome in pregnancy today. And because it's the first time for me to see you today, I want to ask you some question to know more about you. I may need to examine you, need to run some investigation or some test. At the end, I will give you some patient information leaflet and the contact number. Okay, this is how to put agenda in the start of your task. Then normally you start the information gathering by the history present illness, and you know this patient normally have a kidney problem or eye problem. Okay, she may have an eye manifestation. She may have an e problem. Usually, she have hereditary sensorineural hearing loss. All right. So we ask about the history present illness. Normally, we ask by start by open question. Yeah, like could you tell me more about your disease? When was the last consultation with your specialist kidney doctor? When was the last consultation with your eye and ear doctor? Any recent recommendation, any medication for that? She may say, for example, she is using ACE inhibitor like lisinopril, and this for the hypertension. We know that the ACE inhibitor is contraindicated in pregnancy because it decreases the amount of the water around the baby, and it should stop that and exchange it to another suitable, safe antihypertensive medication like the labetalol or methyl-dopa, right? So if she is taking any of the ACE inhibitor or the ARBs, we should stop this medication straight away and check whether she stopped it or still taking it, right? And if she's still taking it, we have to stop this medication and change it to safe drugs. Then we ask about whether this patient talk about her management plan. Whether this patient talk about her plan to get pregnancy with her specialist doctor or no. All right, he may advise her against pregnancy. He may have a new recommendation for her. Right, so she may have unstable kidney function, so to get pregnant now is not suitable for her. So check whether she talk about this the plan of getting pregnant with his specialist doctor or no. How he control her disease, when was her last kidney function, and what was the result. Okay, and how she feel right now. Then go through the remaining history as we used to do, like the obstetric history, whether she was pregnant before, is this planned pregnancy or no, okay? And if it is unplanned pregnancy, whether she want to continue on this unplanned pregnancy or she is happy to do. If, for example, the patient is get pregnant on the unknown, like our patient today, so for how long she had this implanon, okay, because you know that the implanon may be for a long time, the patient forget it, okay, so why she didn't remove this implanon, for example, after 3 years. But our case today has the implanon for 1 year. Okay, and we will talk about, she will ask you about this later on, why she get pregnant on the implant. Then check the blood group, any scan in this pregnancy, any test done, and her future plan for pregnancy. Then go through the gynecological history. Okay, ask about her period in detail, ask about the contraception. As we mentioned before, she is on Planon for 1 year now. Go through the remaining history, medical history, like hypertension. This patient, most of the patient who has a kidney disease may have a hypertension. If she is, did she has any renal dialysis, started renal dialysis for her Alport syndrome? Did she has any renal transplant before or no? Okay. And then drug, what is the medication she is using now? Like we said, lisinopril, and we have to stop this lisinopril, whether she started her folic acid or no, whether she had any allergies at all. Okay, allergies is very important in a patient safety. Then check the social habit like the smoking, alcohol, support at home, very nice. Whether she live with anyone right now, and whether this partner is supportive, and does he has also partner, does this partner have Alport syndrome? Okay, because it will affect on the inheritance of the Alport syndrome to her baby, right? Then mental health, any pregnant woman which have to assess her mental health by the two-hole question. During the last 4 weeks, have you been bothered by feeling low? During the last 4 weeks, have you been bothered by loss of interest in doing things? Then ask about the family history, okay, because this patient, as we mentioned, the Alport syndrome run in families. So yeah, ask about the family history of this Alport syndrome. She may say, yeah, her mother and her brother has Alport syndrome, and they are on renal dialysis for that. Check whether she need to add anything today. Then offer examination of the patient, like usually the vital signs, and also including the blood pressure and the protein in urine. In any pregnant woman, in the antenatal visits, we have to check her blood pressure and check her urine dipstick. Take her through the course of the pregnancy in the woman with Alport syndrome. So normally when we talk about any medical disorder in pregnancy, we talk about the effect of this disease on the pregnancy and the effect of the pregnancy on this disease. So what is the effect of Alport syndrome on pregnancy? So the mother may have a preeclampsia, okay, which is raising the blood pressure and the protein in urine. They may have a worsen of her kidney function. This delivery may be ended by cesarean section. The baby may be grow smaller than expected, which is a CGA, may be delivered early. This is called the preterm labor, and in very rare cases, the baby may die inside the womb. It's called a stillbirth. The most important thing is that this condition, inherited condition, and it may run to the baby. Okay, so as it inherited condition, it run in families by many ways. So, for example, sometimes it is linked by the X chromosomes, and in this case, if it is X-linked dominant, as we mentioned, the risk will be 1 in 2. So what will be the care of this woman? Normally, when we talk about any pregnant woman, we talk about the antenatal and delivery and the postnatal period. So in the antenatal period, this woman she need a multidisciplinary team, which include the consultant obstetrician, specialist doctor in the kidney, the nephrologist, and she may she will need a genetic counselor and the expert midwife. Genetic counselor is very important here to talk with her about the inheritance of her gene to her baby. What is the percentage, and how we can avoid that. So normally this patient will need a prenatal invasive testing, which is called, which is the needle test, the amniocentesis or current villus sample, which will take a small amount of the water around the baby, and this to check whether the baby have the inherited condition or not. Right. Sometimes, if the baby have the same condition, some women may opt to termination of the pregnancy. Normally, if this patient come in the preconception antenatal clinic, so we will offer pre-implantation genetic diagnosis. So she will have a frequent visit in the consultant-led unit, And every time she will have a blood pressure and the protein in urine to exclude the hyperpressure and the preeclampsia. She will have the routine booking a blood test, and we will add to this a renal function test and also PCR and midstream urine to exclude any urine infection. She will have the normal scan, she will have the dating scan and Down syndrome screen as any woman, and also a normal scan. We will add for this woman a gross scan, and this will from 26 weeks because this is a high risk baby for small for gestational age. If she has anemia, if she has anemia during the pregnancy, she will be treated as any other woman with iron supplementation. Sometimes we need to give her an erythropoietin hormone. She will have a low dose aspirin, and this to prevent the preeclampsia. She will have also low molecular weight heparin if the PCR is more than 300. If she's receiving any um, immunosuppressive drugs like dactylorubicin or cyclosporine, this level of these drugs need to be checked monthly because the level will be decreased during pregnancy because of the metabolism. People who are taking calcineurin inhibitors are at risk to have gestational diabetes, so they will be checked for the GDM in pregnancy, and also the people who have steroid. We aim to keep her blood pressure with the normal, which is 135/85. During the intrapartum, normally we will aim for a vaginal birth unless the cesarean section is indicated. This will be in a consultant-led unit, and so the home birth or midwifery care will be not suitable for this patient. So this should be in a consultant-led unit, and where expertise in the renal condition will be available there. During the delivery, the painkiller is avoided or contraindicated, like the non-steroid anti-inflammatory drugs, and also she will need the continuous monitoring of her baby. She will need regular monitoring of her vitals, blood pressure, and respiratory rate, and strict fluid balance. The fluid balance is very important in this case because this patient may easily go to AKI or may go to pulmonary edema, right? So we have to check a strict fluid balance during her delivery. We assess her kidney function every 24 hours, and if this patient receive steroid prednisolone for more than 2 weeks, so we need to give her stress dose of the hydrocortisone 100 milligram every 6 hours till delivery. Sure, any patient with hypertension, we avoid the ergometry. Postpartum, there will be baby doctor who check her baby. For example, if she is receiving steroid, some people may have thymic hypoplasia. We will aim to keep the blood pressure with the normal. We'll avoid non-steroid anti-inflammatory drugs, and she will be reviewed again by her kidney specialist. If she want to return back to the ACE inhibitor, enalapril is safe, and we monitor her vitals and strict fluid balance, as we mentioned before. Contraception for this patient, the progesterone only contraception is safe for this patient. She may ask why I get pregnant on implanon. So implanon is the most effective contraception. About the failure rate is about 1 in 2,000. But any contraception has a failure rate. As we mentioned, the failure rate of this one is about 1 in 2,000. If the patient receives biologics at any time, so the baby should avoid life attenuated vaccine for 6 months, like BCG, MMR, oral polio, and varicella. There's some reference about our case today. Thank you.